It's a pleasure to be with you. The title of this session is Environmental Public Health Practice, Part 5, Zoonotic and Vector-Borne Diseases. There are no disclosures for this presentation. Objectives include review key terms related to zoonotic and vector-borne diseases, review a sample list of zoonotic and vector-borne diseases caused by bacteria, viruses, parasites, rickettsia, and prions. Review the Black Plague, Dengue, Ebola, Malaria, Rocky Mountain spotted fever, Creutzfeldt-Jakob, and mad cow disease. Medical and public health made great strides to control infectious diseases in the 20th century, including the development of numerous vaccines, antibiotics, improved sanitation, disinfection of water, and improved food storage and handling. By the mid-1960s, some health leaders felt that within a few years, infectious disease threats would be eradicated. That didn't happen due to several factors, including human migration, international travel, urbanization, misuse of antibiotics, public health disparities, organism mutations, and climate change, etc. The terms emerging and re-emerging infectious diseases are used to describe newly identified infections and the resurgence of known infections. This session will focus on zoonotic and vector-borne diseases that are often influenced by environmental factors. A few key terms for this session include zoonosis, vector, and vector-borne disease. Zoonosis is defined as an infectious disease caused by an infectious pathogen transmitted between non-human organisms, usually vertebrate animals, and humans. A vector is any living organism that carries and transmits an infectious pathogen to another living organism. A vector-borne disease is a human illness caused by infectious pathogens that are transmitted by vectors. There are more than 200 zoonoses and vector-borne diseases caused by bacteria, viruses, parasites, rickettsia, and prions. Let's review a sample list from each of these categories. Bacterial zoonoses and vector-borne diseases include leptospirosis, anthrax, cat scratch disease, E. coli 0157H7, Lyme disease, plague, psittacosis, salmonellosis, tularemia, campylobacteriosis, yersiniosis, and brucellosis. Viral zoonoses and vector-borne diseases include viral hemorrhagic fever organisms, including dengue, hantavirus, and Ebola. Viral hemorrhagic fever is generally a multi-system disease that impacts the vascular system, often accompanied by hemorrhage. These viruses can cause mild to severe disease, causing death. Dengue is not only a virus that causes hemorrhagic fever, but is also an arbovirus, since it's transmitted by the Aedes mosquito. Hantavirus is in the family of Bunyaviridae. The hantavirus hosts are rodents, including the cotton rat, deer, and house mouse. Hantavirus is transmitted to humans through the inhalation of aerosolized urine and feces of infected rodents. Other zoonotic and vector-borne viruses include the hoof and mouth virus, influenza including avian and swine flu, and rabies. Hoof and mouth disease is an aphthovirus disease primarily infecting cattle, pigs, sheep, goats, hoofed wildlife, and rarely humans, where its name changes to foot and mouth disease. Symptoms include high fever for 2 to 6 days, blisters inside the mouth, making it difficult to eat, and near the hoof or foot, which can be quite painful. Arboviruses are those that are transmitted to humans through an arthropod vector and includes dengue, as previously mentioned, along with West Nile, a flavivirus, Rift Valley fever, yellow fever, and several viral encephalitides. The arboviral encephalitides include Eastern equine encephalitis that is seen in the eastern and northern US, Canada, Central, South America, and the Caribbean islands. Western equine encephalitis is seen in the western and central US. Japanese encephalitis is seen in the Pacific Islands, Eastern Asia, and India. St. Louis encephalitis is seen across North America, Argentina, and the Caribbean islands. Tick-borne encephalitis is seen in the old Soviet Union, Eastern and Central Europe, Scandinavia, and United Kingdom. Venezuelan encephalitis is seen in North, Central, and South America. The California serogroup of encephalitis that includes La Crosse virus is seen primarily in the United States. The vectors of these encephalitides include mosquitoes, midges, ticks, and sandflies. The reservoir host for many of these viruses includes birds and small animals. West Nile virus and Rift Valley fever can also cause encephalitis. Parasitic zoonoses include cryptosporidiosis, cysticercosis, toniasis, giardiasis, leishmaniasis, trichinosis, toxoplasmosis, and malaria. Malaria is a major vector-borne disease caused by Plasmodium falciparum, vivax, ovale, and malariae. Plasmodium knowlesi, which also causes malaria in humans, is considered a zoonotic disease, since it appears to require a natural intermediate host, the macaque monkey, for transmission to humans. Rickettsial zoonoses include Q fever and Rocky Mountain spotted fever. Prion zoonoses include variant Creutzfeldt-Jakob disease and mad cow disease. Variant Creutzfeldt-Jakob disease is the human variety of mad cow disease. This slide lists some of the domestic and wild animals associated with zoonotic diseases. We will now discuss a few examples of zoonotic and vector-borne disease in more detail. Let's now briefly discuss bubonic plague, also known historically as the Black Death. The Black Death was a pandemic occurring in Western Eurasia and North Africa from 1347 to 1353 and is considered the worst and most fatal pandemic recorded in human history, resulting in an estimated 75 to 200 million deaths. The Black Death, also known as the bubonic plague, is caused by Yersinia pestis, a bacteria spread primarily by fleas. It can also be spread through person-to-person contact by aerosols from individuals manifesting pneumonic plague or infection of the lungs. This person-to-person spread is likely the reason it spread so quickly in the 14th century. The origin of the Black Death is unclear. The organism was likely introduced to Europe during the siege of Kaffa in Crimea by the Golden Horde army of Jani Beg in 1347. This map shows the likely spread of the Black Death from Crimea, circled in red, to Western Asia, the Middle East, North Africa, and Europe. It was carried by fleas on rats inhabiting ships throughout the Mediterranean, North Africa, Western Asia, and Europe. The plague caused religious, social, and economic upheavals. Venice, Italy suffered through more than 22 outbreaks of bubonic plague between the 14th and 18th centuries. In 1576 to 1577, the plague killed approximately 50,000 people, or 1/3 of the city's population. During the 17th and 18th centuries, measures were taken by the Venetian administration to combat the disease. Even though the scientific basis of plague was unknown, the Venetians recognized its transmissible nature and successfully decreased its spread by implementing an information network and activating a system of military inspection garrisons along the coast to control all local movements in plague-infested areas, essentially imposing quarantine and isolation protocols. Quarantine applies to those exposed to an infectious organism and isolation to those infected. In contrast to Venice, where the infection was controlled, the neighboring coast of mainland Greece, which was under Ottoman rule, experienced marked infections and deaths during the same period. So even in the absence of scientific knowledge, careful observation and implementation of isolation and quarantine measures can effectively control infectious outbreaks. This 2016 map shows areas of the world where Yersinia pestis is still endemic, including the western half of the United States. The mortality rate of plague, if untreated, is 50 to 60%. Prevention consists of education of the public, the use of insecticides to kill fleas, suppress the rat population, rat-proof housing, isolation for those infected, quarantine for those exposed, the disinfection of the clothing and personal articles of those infected, and the select use of vaccines for research and lab personnel working with the organism. The only plague vaccine available in the US is an inactivated vaccine. There are live attenuated and recombinant vaccines available in other countries. Let's consider dengue for a few minutes, which is among the most significant mosquito-borne viral infections infecting humans. Dengue is passed primarily by the female Aedes aegypti, but also Aedes Asian tiger and albopictus mosquitoes. The incubation period for the disease is 4 to 13 days. There are 5 distinct serotypes, with the 5th identified in 2013. Recovery from one strain provides lifelong immunity for that strain. Infection with a different strain after recovery from a previous infection can result in dengue hemorrhagic fever through a suspected mechanism called antibody enhancement. Dengue hemorrhagic fever occurs more commonly if someone has recovered from infection with type 1 and gets reinfected with type 2 or 3, or if initially infected with type 3 and then reinfected later with type 2. The mortality rate from dengue hemorrhagic fever is 2.5%. This map shows the areas of greatest risk for dengue infection, which includes tropical areas of Africa, Central and South America, and Asia, but also includes South Texas and Florida due to the expansion of Aedes habitat. Dengue infects approximately 50 to 100 million people per year. The Aedes aegypti mosquito likes to live near homes and is a day-biting mosquito. This slide lists common symptoms and signs of dengue fever and include flu-like symptoms of headache, fever lasting 2 to 7 days, eye pain, myalgia, joint pain, lethargy, a maculopapular skin rash, and gastrointestinal symptoms of diarrhea, nausea, and vomiting. Dengue hemorrhagic fever occurs during a second infection from a different dengue serotype. The main symptoms and signs of this serious infection include hemorrhage, hypotension, shock, and neurologic symptoms and cognitive impairment. As previously mentioned, dengue hemorrhagic fever is associated with a 2.5% mortality rate. This is a picture of a child with hemorrhage associated with dengue hemorrhagic fever. Denvaxia, a dengue tetravalent vaccine developed by Sanofi Pasteur, was approved by the FDA in May 2019. Denvaxia is given in a 3-dose series at 0, 6 months, and 12 months. It is indicated for the prevention of dengue disease caused by dengue virus serotypes 1, 2, 3, and 4, and was approved for use in individuals 9 through 16 years of age with laboratory-confirmed previous dengue infection and living in endemic areas. This may protect those individuals from dengue hemorrhagic fever. Endemic U.S. dengue areas include the Caribbean islands of Puerto Rico and the Virgin Islands, along with Pacific islands that are under U.S. jurisdiction. Outbreaks in Hawaii have occurred since 2001 and are associated primarily with the Aedes albopictus vector. There have been small outbreaks of dengue in the continental United States, including Texas, since 1980 and South Florida since 2009. Other states with dengue vectors include Georgia, Alabama, Louisiana, South Carolina, North Carolina, Arizona, and California. Let's spend a few minutes discussing another virus that causes hemorrhagic fever, Ebola. Ebola is an ortho-Ebola virus that causes hemorrhagic fever primarily in sub-Saharan Africa. Ebola was first described in 1976 and has reemerged above endemic rates in 1995, 2014 to 16, and 2018 to 20. Ebola is a zoonosis since it infects humans and animals. Ebola is transmitted through contact with the body fluids of an infected sick or dead person, and rarely through contact with an infected animal, for example, bat, antelope, or primate. The incubation period is 2 to 21 days. Symptoms include sudden onset of fever, headache, diarrhea, vomiting, and unexplained bleeding. The case fatality rate may be as high as 80 to 90%. Prevention when traveling to Ebola endemic areas includes avoiding contact with blood and body fluids like urine, feces, saliva, sweat, vomit, breast milk, amniotic fluid, semen, and vaginal fluid from people who are sick. Clothing, bedding, needles, medical equipment, or other items that may have touched an infected person's blood or body fluids. The body of someone who is suspected or confirmed to have had Ebola disease, such as during a funeral or burial practices. Bats, forest antelopes, primates, and blood, fluids, or raw meat from these or unknown animals. The U.S. Food and Drug Administration has approved an Ebola vaccine called Ervebo. Vaccination is recommended for U.S. adults 18 years and older who are at potential risk of exposure to the Ebola virus. Let's discuss malaria for a few minutes. This table presents the global burden of major parasitic diseases. The global burden order is determined by their daily impact in millions. The disability adjusted life year, or daily, was first used in 1993 in the World Development Report of the World Bank. A detailed discussion of how dailies are calculated is beyond the scope of this session. A daily is a health gap measure. Daily is a measure of overall disease burden expressed as the cumulative number of years lost due to ill health, disability, or early death. The formula for daily equals YLD, or years lived with disability, plus YLL, or years of life lost. The top 10 parasitic diseases ordered by their impact on dailies include malaria at the top of the list, with a daily impact of 65.5 million, followed by cryptosporidiosis at 8.4, leishmaniasis at 4.3, foodborne trematodiases at 3.6, schistosomiasis at 3.1, hookworm and amoebiasis both at 2.2, lymphatic filariasis at 2.0, ascariasis at 1.3, and congenital toxoplasmosis at 1.2. Malaria infects approximately 198 million people, resulting in over 580,000 deaths annually. Malaria is one of 5 major causes of death in children under 5 in developing countries. The 5 major causes of death in children under 5 are malaria, malnutrition, diarrhea, pneumonia, and HIV/AIDS. In the Gambia, from 1960 to 1990, 1 out of every 25 children under 5 years old died of malaria. There are 5 species of malaria that infect humans: Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, Plasmodium falciparum, and Plasmodium knowlesi. Plasmodium knowlesi was thought to be a parasite of macaque monkeys and was used in the past to treat syphilis by inducing a fever in humans. It has now become one of the most common causes of human malaria in Malaysia and other Southeast Asian countries. 10% of knowlesi infections are severe. 1 to 2% of knowlesi infections are fatal. This is the life cycle of malaria. There are essentially 3 phases in the malaria life cycle: sporogony, exoerythrocytic schizogony, and erythrocytic schizogony. The mosquito phase is where the parasite forms sporozoites that are infectious for humans from gametocytes through a process called sporogony. This mosquito phase is the sexual phase of the parasite. This process of transforming gametocytes into sporozoites takes place within oocysts attached to the stomach wall of the mosquito. Sporozoites are then transmitted to humans via a mosquito bite. The sporozoites are then transmitted to the liver through the bloodstream. The human phase are the asexual phases of the parasite. In liver cells, the sporozoites produce merozoites that are then released into the bloodstream to invade red blood cells. This liver phase process, where merozoites are formed from sporozoites, is called exoerythrocytic schizogony. Plasmodium vivax and ovale can create hypnozoites in the liver, latent organisms that can remain dormant for months to years within liver cells and then develop into merozoites months to years later, causing symptoms of malaria long after leaving a malarial area and being free of malaria symptoms. Plasmodium falciparum and malariae don't develop hypnozoites, therefore don't have a latent phase like vivax and ovale. The blood phase is a cycle where merozoites from the liver enter red blood cells and transform to trophozoites and then schizonts that are composed of many merozoites. These schizonts eventually burst, releasing merozoites into the bloodstream that subsequently enter more red blood cells. Eventually, after several cycles of merozoites, trophozoites, and schizonts, gametocytes are formed that are infectious to mosquitoes when they bite an infected human, completing the entire life cycle. This blood phase of the malaria life cycle is called erythrocytic schizogony. Almost all malaria drugs treat the blood phase of malaria. As previously mentioned, Plasmodium vivax and ovale leave latent hypnozoites in the liver that can reemerge as a malaria relapses months to years later. Primaquine treats the hypnozoites in the liver. So after treating the blood phase of vivax and ovale, treatment with primaquine will eliminate the hypnozoites in the liver and prevent future relapses. Malaria is only transmitted by Anopheles mosquitoes. These mosquitoes generally remain within 2 to 4 kilometers of their breeding site. They like to live and feed inside buildings, primarily during dusk to dawn, factors that enhance malaria transmission to humans. Prevention includes controlling the mosquito vector by use of insecticides and larvicides and practicing personal mosquito bite precautions. It's not easy to eliminate all mosquitoes within 4 kilometers of human dwellings, emphasizing the importance of practicing personal mosquito bite precautions. The incubation period is the time between exposure to an infection and the appearance of the first symptoms. This table lists the incubation periods for Plasmodium falciparum, vivax, ovale, and malariae. The incubation period for falciparum is generally 12 days, with a range from 8 to 17 days. For vivax and ovale, it's 9 days to 2 years due to the latency of hypnozoites in the liver. The incubation period for malariae is 28 to 30 days. Plasmodium falciparum causes more severe disease than Plasmodium vivax, ovale, and malariae. Malaria infection during pregnancy is associated with an increased mortality and low birth weight for the baby. Congenital transfer of malaria via blood can occur during pregnancy, causing congenital malaria in the baby. This is primarily associated with vivax and occurs in 16 to 34% of cases where the mother is infected. Since the blood phase of malarial organisms are the only ones transferred to the baby during pregnancy, the baby has no latent hypnozoites when the mother is infected with vivax or ovale. Therefore, the baby will only need to be treated with antimalarials that treat the blood phase of the organism. Congenital malaria is more common in non-immune mothers who have a 7.4% chance of transmitting the infection to their baby versus immune mothers at 0.3%. The onset of symptoms in congenital malaria is approximately 3 to 5.5 weeks post-birth. Treatment would be with an appropriate blood phase antimalarial drug. Major complications of malaria are more common in women during their first pregnancy, primipara pregnant women. Major malaria complications in pregnancy include hypoglycemia, anemia, and pulmonary edema or adult respiratory distress syndrome. Malaria is a major concern for pregnant women in malaria endemic areas. Pregnant women should avoid travel to malaria endemic areas. Malaria is the #1 life-threatening infectious disease risk for travelers. Up to 30,000 European and North American travelers are infected annually. The mortality for Plasmodium falciparum infections in non-immune infected individuals is 4%, with a range of 0 to 8.7%. For individuals who develop severe disease, which includes cerebral malaria, severe anemia, and renal failure, up to 20% die. U.S. President Franklin D. Roosevelt signed a bill that created the Tennessee Valley Authority, TVA, on May 18, 1933, that gave the federal government oversight responsibility to develop the hydroelectric potential of the Tennessee River, improve the land and waterways of the region, and develop a malaria control strategy and program for the Tennessee River Valley. Malaria affected 30% of the population in the region when the TVA was first incorporated in 1933. The Public Health Service played a vital role in TVA malaria research and control operations, and by 1947, the disease was essentially eliminated. Mosquito breeding sites were reduced by controlling water levels and insecticide applications. Malaria Control in War Areas, MCWA, was established and operated from 1942 to 1945 to control malaria around military training bases in the southern United States and its territories, where malaria was still problematic. Many of the bases were established in areas where mosquitoes were abundant. The MCWA aggressively tried to control mosquitoes that could feed on malaria-infected soldiers in training or returning from malaria endemic areas. During this time, the MCWA also trained state and local health department officials in malaria control techniques and strategies. The Centers for Disease Control and Prevention, CDC, developed out of the work and structure of the MCWA and was organized on July 1st, 1946, and initially called the Communicable Disease Center. Much of the early work done by CDC was concentrated on the control and elimination of malaria in the United States. With a successful reduction of malaria in the United States, the CDC transitioned its primary mission from malaria to the general prevention, surveillance, and control of other diseases, both domestically and internationally. The CDC still works to control malaria internationally. These maps show the progress of malaria control from 1900 to today and some projections for the future. Red indicates high prevalence of infection and risk. Pink represents areas in the process of controlling the disease. Blue indicates areas that have controlled malaria for greater than 3 years. In 1900, malaria was worldwide. By 1970, Europe and North America had essentially become malaria-free. In 2020, malaria is still a major health issue in South America, Sub-Saharan Africa, South and Southeast Asia, and the Western Pacific Islands. By 2040, the world could be malaria-free if adequate malaria control resources are committed to the effort. Let's now turn our attention to the prevention of malaria. Simple prevention techniques can be 98% effective in preventing malaria. These prevention strategies will also significantly impact not only malaria, but many other mosquito-borne illnesses. As mentioned previously, without precautions or anti-malarial prophylaxis, the infection rate for non-immune individuals is approximately 1.2% per month, or 14.4% per year. These are 8 prevention measures for malaria that, if used appropriately, can reduce malaria transmission by 98%. 1. Use insect repellents from dusk to dawn. 2. Use insecticide sprays containing pyrethrum. 3. Use permethrin impregnated bed nets and clothing. 4. Wear blousy, long-sleeve shirts and pants. 5. Stay in mosquito-free screened areas from dusk to dawn. 6. Use appropriate prophylactic medications. 7. Cover water containers. And 8. Use larvicides. Insect repellents should be used from dusk to dawn, the main feeding time for Anopheles mosquitoes. Insect repellents to consider include DEET, N,N-diethyl metatoluamide, picaridin, and oil of lemon eucalyptus. Oil of lemon eucalyptus works well and lasts as long as low-dose DEET. 2. Use insecticide sprays containing pyrethrum. Pyrethrum kills on contact. Consider using pyrethrum-containing sprays in living rooms and bedrooms in the evening when Anopheles mosquitoes feed. 3. Use permethrin-impregnated bed nets and clothing. Permethrin binds to fabrics and will continue to repel mosquitoes even after several washings. 4. Wear blousy long-sleeve shirts and pants. 5. Stay in mosquito-free screened areas from dusk to dawn. Number 6 is use appropriate prophylactic medications based on anti-malarial resistance patterns in the endemic area and medication contraindications. Generally, if in a chloroquine-sensitive area, use chloroquine. Mefloquine and malarone, atovaquone proguanil, are some of the most common medications used for most malaria risk areas of the world. Number 7 is cover water containers to decrease breeding sites near houses. There can be a role for larvicides, number 8, but they will likely have a limited impact since Anopheles mosquitoes can travel up to 4 kilometers to feed. Therefore, to be effective, all standing water within that 4-kilometer radius would need to be treated with larvicide, which would be difficult in most malaria endemic areas. In 2021, the World Health Organization, WHO, formally recommended RTS-S malaria vaccine for children in sub-Saharan Africa and in other regions with moderate to high malaria transmission. This is the first time ever that a vaccine has been recommended to combat malaria, a disease that has killed billions of people globally over many centuries. This slide is adapted from Global Malaria Strategies developed by the U.S. Agency for International Development, USAID. USAID suggests 2 major categories of global intervention to support malaria control: technical and research and innovation. Technical interventions would include indoor residual spraying with insecticides programs, the organized timely spraying of an insecticide on the inside walls of houses or dwellings to kill adult mosquitoes before they can transmit malaria parasites to another person, distribution of impregnated bed nets, and education on their appropriate usage, insecticide-treated mosquito nets hung over sleeping areas protect people by repelling mosquitoes and killing mosquitoes that land on those nets. Intermittent preventive treatment for pregnant women involves the administration of antimalarial drugs to pregnant women at each prenatal visit, which protects them against maternal anemia and reduces the likelihood of low birth weight and perinatal death in their infants. Diagnosis and treatment programs entails diagnostic testing for malaria to ensure that all patients with malaria are properly identified and receive a quality-assured artemisinin-based combination therapy, ACT. Seasonal malaria chemoprevention programs is an approach used to prevent malaria among young children in parts of the African Sahel subregion with highly seasonal malaria transmission. It entails the administration of a curative dose of antimalarial drugs at monthly intervals to children without malaria symptoms in a targeted area over a limited transmission season. Cross-cutting interventions include social and behavioral change communications, operational research, health system strengthening, and surveillance monitoring and evaluation. Research and innovation includes drug efficacy monitoring programs to document the emergence of antimalarial resistance, research to develop effective malaria vaccines, identify novel insecticide-based vector control tools, and develop new anti-malarial drugs. Let's now consider Rocky Mountain spotted fever. As demonstrated on the map, Rocky Mountain spotted fever is seen primarily in the east, southeast, and midwest of the United States. Rocky Mountain spotted fever is caused by a rickettsial organism called Rickettsia rickettsii. Rickettsia are unusual organisms that reproduce within cells like a virus, but require oxygen to survive and are susceptible to antibiotics like bacteria. The vector and reservoir for Rickettsia rickettsii is the dog tick in the southeast and Rocky Mountain wood tick in the west. These ticks can transmit infection to humans and domestic animals like dogs. Within the first 4 days of infection, symptoms include fever, headache, gastrointestinal symptoms, nausea, vomiting, anorexia, abdominal pain, muscle pain, rash, and edema around the eyes and back of the hands. After day 5, symptoms may include altered mental status, coma, cerebral edema, respiratory distress, skin and soft tissue necrosis, and multi-organ failure, for example, kidney failure. Treatment is with doxycycline. The case fatality rate without treatment is approximately 25%. Let's now consider rare prion diseases, variant Creutzfeldt-Jakob disease in humans, and mad cow disease in cattle. Mad cow disease is also called bovine spongiform encephalopathy. It's likely caused by misfolded proteins called prions that disrupt neurons and cause degeneration of brain tissue, as demonstrated in the MRI on this slide. Human disease is called variant Creutzfeldt-Jakob disease, VCJD, and is thought to be caused by eating food like beef that contains bovine spongiform encephalopathy prions. These diseases are incurable and invariably fatal. Initial symptoms include psychiatric problems, behavioral changes, and pain progressing to poor coordination, dementia, and involuntary movements. The length of time between exposure and symptom onset is believed to be years to decades. The average life expectancy after onset of symptoms is 13 months. These are rare diseases with an annual incidence of 1 per million. In summary, despite medical and public health advances, Zoonotic and vector-borne infectious diseases continue to threaten the health of people globally. The vectors for arboviral encephalitides include mosquitoes, midges, ticks, and sandflies. Even in the absence of scientific knowledge, careful observation and implementation of isolation and quarantine measures can often effectively control infectious outbreaks. Dengue is among the most significant mosquito-borne viral infection infecting humans. Of parasitic diseases, malaria has the highest disability-adjusted life year score. Simple prevention techniques can be 98% effective in preventing malaria. The Rocky Mountain spotted fever case fatality rate without treatment is approximately 25%. Prion diseases are incurable and fatal.